And we talk about vaginal hormone, which is the one that best prevents UTIs in postmenopausal women. So, Dr. Bill, you're probably an expert on this, but I was not when I was introduced to this information. So, we use vaginal hormones for dryness or libido, but when it comes to atrophy and recurrent UTIs, which one actually works? So, I'll keep it evidence-based first and fast, and estrogen, DHEA, or testosterone. So, who wins this war, right? So, bottom line up front, vaginal. Estrogen has the strongest and most consistent evidence for preventing recurrent UTIs. So we're not talking about lubrication here, atrophy. It's more about UTI prevention. The landmark RCT from 1990s actually showed that postmenopausal women using vaginal estrogen, on this study they used rings or creams, had significantly fewer UTIs over 6 months compared with placebo. The Cochrane review and latter studies confirmed this, showing not only fewer infections, but also improved vaginal pH and restored protective lactobacilli. Mechanistically, it makes perfect sense. Why? Estrogen thickens the vaginal epithelium, increasing glycogen, which feeds the lactobacilli, lowers the pH, and reduces colonization of uropathogens. So, guidelines from multiple societies now recommend low dose local estrogen as the first line non antibiotic strategy to prevent UTIs in postmenopausal women. So practical dosing, estrogen cream, zero point 0.1 milligram per gram. So 1 gram daily for 2 to 4 weeks and 1 to 3 times weekly for maintenance. And vaginal tablets or rings work similarly with minimal systemic absorption when used locally. The second one is, of course, prasterone, as we know, or vaginal DHEA. Promising, but not yet that proven. So it's the next option, and it's FDA approved though for vulvovaginal atrophy and local, I guess, local converts to estrogens and androgens into the vaginal tissue. 2022 observational study found that women using prasterone had improved mucosal health, fewer reported UTIs, especially those unable to use estrogens, like breast cancer survivors, for example, who are on aromatase inhibitors. However, these results are preliminary. Large RCT trials are underway in relation to, again, UTI prevention. DHEA cream, 10 milligrams per gram, 1 gram daily, 2 to 4 weeks, then 1 to 3 times weekly, almost similar to estrogen. And again, lastly, would be testosterone. And the classification of prevention of UTI, it's still experimental, unfortunately. And small pilot studies like OUP Academic 2023 are exploring this, but we don't have controlled data yet. So it's different to, again, lubrication and I guess addressing atrophy. It's more of prevention of UTI. So recommended doses would be, it's quite a range, 300 micrograms to 1 milligram per application daily, several days a week. And again, this is something very broad. So takeaways, vaginal estrogen, best proven, guideline backed, and effective for both vaginal health and UTI prevention. DHEA, promising and physiologic, but still under study. Testosterone, interesting, but currently experimental. So if vaginal hormones were kitchen tools, estrogen is your proven nonstick pan, keeps UTIs from sticking around. DHEA is the new designer spatula, looks great, but needs more testing. And testosterone is a prototype gadget still in the box being tested. So, again, that's your tip of the week.
Okay.
Well done.
Yeah.
Well,
So,
thanks.
my experience, I like intravaginal testosterone. I think I got you get more than just the prevention. You really we see menopausal vasomotor symptom relief with vaginal testosterone also. I tend to go towards that. I'm pretty comfortable with it. Use 1 milligram per gram, and I use it once a night for 14 nights, then 3 times a week for 14 nights, and then once or twice a week as needed. It's Carolyn. I don't know what she's her take on that is.
Yes, it's the bomb. The tissue, the where you get dyspareunia, the opening to the vagina full of testosterone receptors. Many women have pain there because of birth control pills and high sex hormone binding globulin. So it's really nice to put it there. The clitoris atrophies, it's good to use it directly on the clitoris too. The bladder and urinary tract tissue is full of testosterone receptors as well, the whole thing. I learned that at Ishwish
Hmm. Okay, there's a question, and then we'll get to Chris. Is there a risk of clitoral hypertrophy?
Um, it-
I've never seen it with the doses we use.
I
If you overdose it, I'm suppose there's a chance of it, but I've never seen it.
We had one doctor had a couple cases. She was using 6 milligrams per gram testosterone cream
Hmm.
and had some hypertrophy, so she backed off.
Yeah, well, that would do it. The AMG guys would probably do that. That's what they do. The guys are taking 7 milligrams of estradiol a day. They're
Oh wow.
the
Oh,
postmenopausal men there.
that's interesting.
That's a whole nother story. Okay.
I just put up a Facebook page, progesterone for men.
Hmm. Oh, okay. I'm going to take a look at it.
Yeah, please come
So,
over there.
in the meantime, Dr. Chris Meletis, who's been with us before and is an educator, international author, and lecturer. His personal mission is changing the world's health one person at a time. Good luck on that. Dr. Meletis believes that when people become educated, their body is the moment when change begins. He's authored 16 books, 200 national scientific articles, including in such journals and magazines as Natural Health, Alternative and Complementary Therapies, Townsend Letter, Life Extension, and Natural Pharmacy. He's served as the Dean of Naturopathic Medicine and Chief Medical Officer for 7 years and was awarded the 2003 Physician of the Year by the American Association of Naturopathic Physicians. Chris has been with us a couple of times before, and we always enjoy his talks. He's very insightful. And Chris, I turn it over to you.
Well, thank you. And I always enjoyed, this is my favorite group, no lie. And, or as the Gen Alpha would say, no cap, which would be no lie. So by the way, I'm a big fan of also hyaluronic acid for those that are hormone avoiding. Hyaluronic acid, there's some nice European studies on the vaginal tissues equal to estrogen in some studies, but not the glycogen side of things, but kind of wonder about the hyaluronic acid also being food for the friendly bacteria. So I'm going to talk about lots of things. Most of you folks already know the vast majority, but if I can tease your synapses on a couple of new novel things, I'll be surprised, but I'll try. And we'll talk about long haul COVID. There's a couple of interesting things. There's an oxaloacetate, which we'll chat about in passing. We'll talk about also a little bit about a new study that's yet to be published. It's coming out November 14th on NAD. But we're going to also talk about how is it that our patients are ill, and however they're ill, however they're tired, however they're worn out. The question is, we have to rise all the ships in the harbor, the 37 trillion cells. When I asked a question back in New York about 14 years ago, I was giving a lecture on genetics and epigenetics. I said, it was 7 a.m. I had flown in at 11 o'clock Eastern Standard Time. And I was a 7 a.m. lecturer, and I was tired. And of course, I always make the joke I had to do my hair. So I told them I was particularly tired, having to be all prim and proper for them. But I said, some of you are tired, but how many cells in my body have to be tired before I feel the tired? I perceive the tired. I can speak of being tired. Is it 1,000,000 cells, 1,000,000,000 cells? And are they brain cells? Or are they adrenal cells? I said, I don't know. I'm going to tell you lots of things I do, but I don't know that. And no answers. And this is at Integrative Health Symposium, lots of medical providers there, lots of medical doctors and osteopathic physicians and other allied healthcare providers. And there was no answer. Then I asked the question, well, how many cells in my finger have to hurt before my finger is perceiving as hurting? And I said, before you answer that, have you not had a paper cut that hurt worse than cutting a tomato and cutting your finger in the kitchen? And the answer is yes. So lots of things which we don't know. So today's conversation will be about the mitochondria, fatigue, and rising all the ships in the harbor at once. So we'll discuss, of course, mitochondrial aspects of chronic fatigue, long haul COVID, which we see a lot of. And I wrote an article for NDNR, which I reference in this presentation. Oxaloacetate, there's some nice clinical trials on oxaloacetate. We all remember that from our basic sciences biochemistry of that lovely citric acid Krebs cycle. We'll talk about NAD, of course, because as many of you know, I do present a lot on NAD. But really the steroidogenesis, and it comes down to our mitochondria. After all, cholesterol touches upon the mitochondria, and the mitochondria says, let me make some pregnenolone. So you make all your other steroidal hormones. And when we educate our patients, why are we doing a pregnenolone? Why don't you just give me estradiol? Why don't you give me a bias? Why don't you give me, well, because the pregnenolone and the DHE, as we know, have independent benefits along the way. Plus, do we just give a person a fish, or do we teach them to fish and backfill? And I find with my andropausal, menopausal individuals and the peripausal individuals that, once again, you have to support all these other factors as well. So we know long haul COVID becomes, it's kind of an old topic these days, but in Geroscience 2024, they spoke to the fact that in 2024, 7% of adults in the United States, about 17 million people, were experiencing some level of long haul COVID. And I have, just in my small little practice, I only practice part-time, the rest of the time I'm a consultant. But I mean, I have a handful of people with long COVID, and some are in that disabled capacity. They're smart, they're capable, but they are chronically fatigued, and they got brain fog and so forth. More than 70% of COVID survivors suffer from some ongoing post-infection, and these are the common symptoms. But there's some 200 diagnosable signs and symptoms for people with long-haul COVID. So this is my NDNR article that I had published in 2025 here, September, and talks about the things which we already knew. The brain fog and the fatigue are big ones. Disequilibrium, dysautonomia, very, very common. Some people will have the paresthesias. Some people will have primarily gut-related issues. But when I look at long-haul COVID, yeah, we can talk about spike proteins, which we'll chat about a little bit, and some of the documented approaches to that as well. But the question is, could this presentation apply to anybody with any chronically fatigue-driven virus, Epstein-Barr virus, cytomegalovirus, herpes 6 virus? I would argue, yes, it could, very much so. And when we get into the nuances of CD38, which of course, over the course of time, starts sequestering NAD, for example, and as part of the aging process, our immune system definitely needs to be fueled properly. But why are these people not bouncing back? And why do some people lose their sense of smell from COVID? And is that a zinc deficiency, which of course is pretty prevalent? Or is it an NAD insufficiency, or is it something else? And why is it that olfactory nerve hit? And knowing the olfactory nerve, cranial nerve number 1, directly conduit into our brain, is there a clue there? So long COVID, adrenal fatigue, syphilis, chronic fatigue syndrome, they have overlapping pathophysiology. It's noted in the peer-reviewed literature a lot, and it all comes back to the mitochondria as a common theme, the only theme. We all know it's not that easy, but a common theme. And so they got the persistent fatigue, they got the brain fog, they got the multi-system dysregulation, including the dysautonomia. And then as a result of that mitochondrial dysfunction, we start seeing oxidative stress, immune dysregulation, metabolic disturbances, endothelial issues. Now, of course, we can go into a whole litany of things about who spike proteins cause hypercoagulability and other things. Another day, another conversation that's not recorded. But we can kind of surmise that, COVID is unique, but is it not a crossover for all our other patients with chronic fatigue as well? I would argue the mitochondria is always going to be something that we focus on. So, but at the same time, well, what about our adrenal glands? Because after all, it comes down to susceptibility. And I'm sharing this information in a primary, very simple way, because we all have to learn, and then we all have to come up with a story to share with our patients. So I share a lot of stories because this is how I relate it to my patients. So of course, I point out the adrenal glands. And so let's say a person was adrenal insufficient. We're not going to say adrenal deficient. We're not Addisonian. They're just creeping along. And then they get walloped with the cytokine storm of a virus like COVID. And then that further taps their adrenal glands. They weren't making the cortisol and cortisone at that 20 milligrams minimal dose physiologically per day. And they're going to have breakthrough symptoms, and they're much more susceptible. And that comes back to the concepts of a germ theory. I shake everybody's hand in this virtual room, but does everybody get my cold that I have? No, because not everybody's equally susceptible. So the adrenals come into play here. But also the adrenals, we think ACTH. And when I talk to most of my colleagues, they're talking about adrenal cortex. And so I apologize. It looks like my landscaper showed up today instead of on Friday. So hopefully I'll talk a little louder so you don't have to hear him too much, but he's clearly making noise out there. So my apologies. So then we have the adrenal glands, we got the cortisol levels, but well, what about the adrenal medulla? how many of us actively treat the adrenal medulla? After all, that's where adrenaline comes from, hence the adrenal glands. Well, we don't, and we'll chat about that today. But when we come to the mitochondria, we see, of course, we got to fuel the zona glomerulosa. And these are all things we learn in histology and pathophysiology class. The zona fasciculata, zona reticularis, but there's a medulla with the adrenaline and norepinephrine levels both. And we start thinking, well, if I was to give somebody an amphetamine, let's call it Adderall, it might help with their attention deficit and help with their brain fog, yes. So once again, if our adrenals are worn out and we don't have a lot of adrenal medulla function, let alone when we get to the locus ceruleus, which we'll chat about in a moment in the brain, it's like, okay, well, we start getting that some more of that brain fog. So is it merely cortisol levels? Of course not. Is it adrenal medulla in part? Yes. And how do we quantify that? Do we do a neurotransmitter test? Do we do a standard blood draw to look for metanephrine and so forth? But I like to look at treating all those tissues. But how can you do that in part? By taking care of the mitochondria. So at least those tissues have the ability to be inherently residual and resilient. But then we get over here to a great 2023. This is a diagram from that journal. And it talks about hyper and hypocortisolism. We all know about hyper. Most of us have practiced long enough to remember that before we had all these biological drugs, we can give somebody like with lupus or something, a whole lot of prednisone, and all of a sudden their symptoms abated because their autoimmunity, their self-attack also went down, their immune system went down. But we see with blunted cortisol levels, we see a milieu of problems and changes in growth hormone levels, but decreased cortisol levels. So once again, that adrenal fatigue person, before they started suffering from long haul COVID or being chronically fatigued and disabled and then having that mental sequelae, they have increased pain sensitivity and decreased pain threshold. But if I gave somebody with bursitis, cortisone injection, their bursitis kind of goes away. Well, but now we're not making our 20 milligrams per day minimum, which is the high, how much we would replace with hydrocortisone per day for a pan-PIT patient, a patient with no pituitary gland, which I have one, which I manage. Then when she gets a fever, I crank it up by 5 or 10 milligrams. So she gets stressed out by watching the news, I have to adjust it because she doesn't have that physiological ability. And she was in a catastrophic accident. Even the endocrinologist say, hey, do 50 milligrams or 100 milligrams of hydrocortisone to save her baby, because otherwise she'll go into adrenal failure. So, but we see here, of course, we have genetic polymorphisms as well. But so that's on the HPA axis. But then we get over here to the sympathetic side of things, and what's going to the adrenal medulla, the splenic nerves. But then we also start seeing that when we're just wired all the time, and whether you have a catecholin-methyltransferase and you're a warrior or the worrier, but you have alteration in your heart rate variability, increased catecholamines, welcome to blood pressure, and even maybe white coat hypertension in part. But we start seeing changes in cognitive well-being. So I argue adrenal gland, cortex, and medulla at once, and treated in concert opposed to just hydrocortisone or adaptogenic herbs, but also giving some inositol tyrosine, giving some other things to support the adrenal medulla as well. And so when they look at hypercortisolism in the peer-reviewed literature, as you can see lots of references on this slide, and they look at what do they find? That some 20 to 25% patients with stress-related disorders, and including chronic fatigue syndrome, chronic pelvic pain, fibromyalgia, interesting, post-traumatic stress, irritable bowel, low back pain, burnout, and atypical depression, they all have a hypercortisolism in common. So it's like, where does that cortisol level fall and where do we want to see it? And I give the example for my patients. If I was to wish them well, I would take away their technology. And then I would say, go to the Caribbean or go to the mountains. I will provide you fresh fruits and vegetables. You will have no connectivity. You get your daily massage and whatever mindful practice you want. And over the course of 6 months with that routine, they're going to start making their 20 milligrams of hydrocortisone. Lots of aches and pains will go away. And it's much like Shinrin Yuku, which is a forest bathing, which we'll chat about briefly. It's like we're just disconnected. We're not grounded. And so once again, we continue to take from the well and deficit spend, and it doesn't work for us. So here's an example of cortisol. Then there's free cortisol levels, just like we have total sex hormone, and then we have sex hormone binding globulin. But then the question is, how does that person present? And I'm sure you do the same thing I do. I'll tell my patients, so in this part is a very sad, pathetic example here. Well, so the only time you kind of feel alive is in the evening and then you're dead to the world. But now, of course, we know the night owl, of course, will have that spike in the evening. The hydrocortisone levels are a little higher, but this is a person's dead to the world. They have breakthrough inflammation. They're fairly miserable. And then you can see this person, like you get ravenously hungry right around 8 or 9 o'clock in the morning, and then you're just scarfing again. Yeah, how do you know that? Because cortisol is the thing that woke us up in the morning from an ancestral perspective. Melatonin started dropping, circadian rhythm, cortisol picks us up. All the things which we know, but I share this with my patients so they understand what this data set means to them. And when we can start reading the tea leaves, so to speak, and say, this is when you feel the best, this is when you feel the worst, and this is when you're out to lunch. And like, how do you know that? Well, that's what your adrenals are telling us. But that's adrenal cortex. Well, what about the adrenal medulla and the sympathetic side of things? So the lucus coeruleus, of course, located in the pons by the fourth ventricle, but it actually releases norepinephrine. And what dampens that release of norepinephrine and blunts it a little bit is having sufficient cortisol levels. So if you don't have sufficient cortisol levels, this is why our patients are dead to the world. Their significant others saying, yeah, I don't know. Sometimes he's just out of it or she's just out of it. Then all of a sudden they're on. The light has switched on. That's because they're on an adrenaline dump and there's not enough hydrocortisone to actually dampen that adrenaline dump. And so they're on, burning the candle at both ends and in the middle, and then they crash even harder yet again because they lose energy they didn't have. So it's interesting to see the locus coeruleus playing a role in that, and that we don't have enough cortical releasing factor or cortical releasing hormone and enough responsiveness from our adrenal cortex. Our norepinephrine is going to run its gamut and cause us to be very unhappy. And this is an example you hear occasionally of a person ripping the car door open after it was jammed and the jaws of life couldn't even get the door off, but the mom did or the dad did. Once again, working on adrenaline survival. But this is my fun part. As we learn more and more, we've learned about the microbiome, and many of you know that I wrote my 18th book on the microbial mucosal milieu and how we have microbiomes throughout the body, the bladder and the prostate and the uterus and onwards throughout the body. Even they argue the bloodstream in the brain. And they all work like the tentacles and neural network of ancient forest. But now the question is, well, how do our mitochondria also work in concert? So we've got our mitochondria here. We got cholesterol, go through the CYP11A1, it's making pregnenolone. Of course, then we're going to make our 17-hydroxyprogesterone, our progesterone, and then we start seeing this whole aspect. But if we don't have the steroidogenic acute regulatory protein working properly, let's argue there's a polymorphism there, then we're going to have truly a mitochondrial dysfunction or a diagnosing mitochondriopathy, which we'll see, didn't have to use an ICD-10 code for. But so much of this is subclinical. But the really part that I like to point out here is we got our cortisol to cortisol back and forth. Well, if I tell my patient, if I have a rash, I put hydrocortisone on, it's going to help with my aches and pains or my rash. Of course, cortisone injection, we get the idea. So if you don't have that, you're going to have breakthrough inflammation and a hyperimmune system and higher CRP, all things being equal. And then, of course, we look at, of course, our aldosterone. And lots of times we'll start seeing with our patient that has adrenal fatigue or adrenal insufficiency that their sodium and potassium are a little off. Well, of course, we're treating the entirety of the adrenal, including adrenal glomerulosa, and that process when we treat the adrenals, ideally, when we take care of the mitochondria. So back to the mitochondria as a simple way to give the energy to the body. And I give a silly little example. Everything is a word salad in my mind. Got a little adrenal gland here, a little Pac-Man or a woman, and you feed us some rhodiola, ashwagandha, ginseng, schizandra, whatever. And all of a sudden, but did you not hear from the doctor that my adrenal glands are tired and I'm tired? So what am I supposed to do with that? I don't have the energy to barely exist, let alone take some other thing and fuel and adapt. And so once again, we have to have the adrenal glands have the energy or the brain or the heart or the muscle or whatever the damaged tissues are to, of course, come back online. So we all know the classical symptomology of adrenal fatigue. It goes without saying. But I like to point out Popeye, olive oil, and this fine fellow, Wimpy, my favorite character back in the day. Not because I thought I was going to grow up to look like him, but I gladly pay you Tuesday for a hamburger today. Classical deficit spending. I'm going to borrow from tomorrow to get through today. And so what we see, of course, is we see fatigue, we see the energy crashes, we see the anxiety, that why you're tired, for sleep. Because also, if a person's cortisol levels drop at night, their blood sugars can go hypoglycemic. And when we get hypoglycemic, what happens? We have an adrenaline dump, which further feeds that vicious catch-22. But we also see with people adrenal insufficiency, they have joint pain, they have brain fog, they have cravings because they're self-medicated, much like the diabetic has the 3 Ps, polyuria, polydipsia, polyphagia. Well, here, they're like, okay, I'm going to fuel myself because I don't have cortisol to maintain my blood sugar. So you get into this vicious catch-22, and or they're craving the salt or whatnot. But I give the example of Popeye when I was growing up. I'm a product of Saturday morning cartoons, and also Betty and Wilma of the Flintstones. They would, of course, be the nemesis for their significant others by saying charge, and they were going to charge with a charge card, a piece of rock there, and pretend like they were going to go spend a lot of money. Once again, borrowing from tomorrow to get through the day. It doesn't work for our government, it doesn't work for our households. So when we look at the adrenal glands and the metronome and fatigue, what is it that causes our patients to be long haul COVID? Adrenal fatigue, worn out. Is it the thyroid gland, the human metronome? When I grew up as a young doctor in 92 is when I graduated. My mentor was Dr. John H. Jeffries. He was a chiropractor, a naturopathic doctor, a medic in the Navy, and he was a pioneer and a rebel. He did in-office ether major surgeries that I, of course, did not participate in. And he did a lot of other creative things, but he also taught me some really great techniques on adjusting the spine. He's just a clever fellow. But we used to take basal body temperature. Some of us might still encourage our patients to monitor their temperature, but that's a metronome. But what is the metronome for? Everything, including our mitochondria, which we'll chat about. We have our adrenal gland resilience, our peak gonadal function. Of course, we know about pre-gonadal senescence. And then we have, of course, fertility as a part of that. Restorative sleep. Of course, I do a lot of testing for apnea. I just diagnosed a 124-pound, 63-year-old woman with moderately severe apnea. And she was wondering why she was having body habitus issues. She eats like a bird. She works out consistently, but she just feels tired to the world. And so our brain, our heart, everything needs it. But it comes down to our mitochondria need to have an aspect of functionality, and our thyroid plays a role in that. But what has caused this young person to lay there and just be white? Did she overexert? Did she have a stroke? Did she have a heart attack? Did she not get enough sleep? Or and how many cells in her body? And what part of their cells? Is it the mitochondria? And so if her adrenals had enough mitochondria, her brain had enough mitochondria, the rest of her body had enough mitochondria, would she be like this in terms of charge? They say when we're 30 years old, we make about 60 kilograms of ATP. And for every decade past that, all things being equal, chronological and biological age, but at the age of 30, we make 60 kilograms. And for every decade after that, we make 10% less. So 60 kilograms, that is per day we make when we're 30 years old. So of course, we're phenomenal recyclers and reusers. So they give an example here of the adrenal cortical cells, some of the processes going on here, ACTH going through the pathway. Here's cholesterol going through our path into the pregnenolone and feeding into pregnenolone to progesterone onwards, but even our adrenal cells. So what are we doing? So we give them our normal protocol, but is part of our normal protocol also to give adrenal support? So what I like about this particular mindset is adrenal support is modular to any of our protocols. So if we're doing fertility, if we're doing brain rehab, if we're doing cardiovascular work, or we're doing whatever it might be, post-surgical work, we're looking at, well, how do I support the mitochondria so that our anabolic and catabolic balance are there? But you also see here acetyl-CoA, and welcome to the world of red yeast rice and the statin drugs. I just have a patient that I diagnosed with prostate cancer. He went off to the Mayo Clinic. He chose to get 5 intense radiation therapies opposed to the protracted radiation, proton. And now his PSA is good, but they put him on a statin drug because there's an aortic bulge. So they put him on a statin drug and he's down to 97 cholesterol. He's excited his cholesterol is so low. I rattle off everything in his body that requires cholesterol. And of course, he's also on hormone blocking, anti androgen therapies as well. So he has no testosterone. His testosterone, serum testosterone was a 2, by the way. His cholesterol is non-existent. His pregnenolone is modest dearth, the same as with his DHEA. But once again, that lovely little cycle here. But how many of our colleagues think about what happens when we start poisoning our cholesterol pathways, start lowering those levels, start altering that feedback loop, and what it's doing to the mitochondria? So we look here at estrogens and testosterone and progesterones. We know that as we started out with a great commentary about vaginal pelvic health, well, estradiol actually helps with biogenesis of the mitochondria. So the question is, when we're starting to do that therapy locally or helping with some mitochondrial support, which also helps with reepithelialization. Now they're taking a good multivitamin with some vitamin A, some folate in terms of methylene tetrahydrofolate. Are we also helping those vaginal tissues become more energy rich to actually take up the nutrients in the body and then, of course, compensate? And if there's friction and traffic in that area, is it also helping them become more anabolic and being compensatory? But when we talk about the mitochondria, we can talk about the steroidal hormones, the steroidogenesis all day long. But it's also where our MAO and MAB, so MAO and MAB, actually degradation comes. So now all of a sudden, if we don't have good, healthy mitochondria, might we have a catecholamine imbalance? Once again, that wired side of things, constantly anxious side of things. And the question which I plant, because I don't know the answer to it, did COVID and COVID illness, whether it be vaccination or whatever we want to call it, and having gotten COVID, because people that even were vaccinated, of course, contracted COVID, even though we were told we weren't going to get it. So the question is, did it also alter the mitochondria? We know it altered the microbiome. There's quite a bit of literature on that, which I won't go through today. But the MAOA and MAOB are breaking down norepinephrine and dopamine. And so it's like, So is that why we're seeing so many more anxious people? Or was it just that we had endured a PSYOPs for 3 to 4 years where we had to follow certain rules and couldn't have here in Oregon more than 3 people to your house? Otherwise, we were supposed to turn our neighbors in. So was it that? Or was it also that our mitochondria got damaged from this process? So then we get to our thyroid gland. And our thyroid gland, when we help a patient, a hypothyroid patient, their TSH is elevated, which is neither here nor there most of the time. Their T4 and T3 are low. The reverse T3 might be on the higher side relative to the where it is on the free T3. But then when you stimulate the thyroid, well, the thyroid stimulates the mitochondria. There's no question about that. And I'll show you some slides on that. So now all of a sudden we're stimulating the mitochondria, but the mitochondria don't have barely enough substrate to get the job done to start with. And this slide is indicating non-alcoholic fatty liver, now of course called MASLD. So it's like all of a sudden, well, when we work on the mitochondria, often fatty liver gets better. The liver enzymes, liver function tests get better. Likewise, when we work on the mitochondria and the thyroid, cholesterol levels start dropping as well. So it's kind of interesting. Once again, we're starting to fuel the energy, the monster, the machine inside us. But do we have enough substrate? So we're now speeding up the mitochondria, and will they start feeling better for a while and then peter out? We all have our patients that I felt better for a while, then it wore off, doc. And why is that? Is that because our therapy wore off, or did we now find the next rate limiting factor? And the answer, yeah, we hit the next rate limiting factor. Your thyroid dosing did not wear off, but what its stimulation to the cells came to the next chink in the armor, the next weak spot. And I give the example with our adrenal fatigue patients, our long haul COVID patients. If we're treating them for thyroid and we go ahead and support their thyroid without supporting the other processes, it's like bug on the windshield. Now you're barely functioning with what was coming towards you, and now it's, and that's going to further stress their adrenals, stress their neurocognitive well-being, and cause them to be absolutely, totally miserable, not by intention. But then we look at the mitochondria from a T2, T3 perspective. So we know T3, we've known this forever, goes down to the mitochondria and the mitochondrial DNA even, and actually speeds things up. So we're speeding up the mitochondria when we get conversion of T4, like levothyroxine, synthroid, to T3. But what about T2? T2 alone has some therapeutic benefits. So is that an argument why we might consider, for not considering halal or kosherness, a porcine-based T3, T4 that's standardized, but it has a non-standardized amount of T2 in it? Is that why some people respond better to a pig-based thyroid or opposed to a levothyroxine cytomel or synthroid cytomel? Is it because that T2 for them floats their boat? It's the soup du jour for them. So I find that as a major thought provocation for today. It's like, now we can see the AMPK pathways and the sirtuins and the PARPs and so forth, both the alpha and the delta. It's like, I'm intrigued. This really, when I was doing research on this slide, I'm like, is that why my patients seem to do better on pig-based? Because you can argue, well, you can give them cytomel and you can give them levothyroxine or synthroid, but sometimes it doesn't float them the same way. Then we have our glucocorticosteroids. Of course, most potent are our anti-inflammatories. We know hydrocortisone is bio-identical, and then we see the suppressing effect, the pro and anti-inflammatory effects, the HPA axis, the immune function. I have down some hydrocortisone cream here as just a very simple example that if a person has adrenal fatigue and you give them hydrocortisone, I have some hydrocortisone right here as a prescription. Well, because I happen to be that flatline fellow that I showed you earlier, and it's like, okay, well, I'm going to have breakthrough inflammation. I'm going to have more neuroinflammation. And therefore, with that more neuroinflammation, am I going to have more brain fog? The answer is certainly yes. So I give the example of hydrocortisone cream for my patients because they get it. They know if they rub that on, their rash is going to get much, much better. And then I say, now imagine that throughout the entirety of your body. And so how do we get your body endogenously to make it? And in the short term, if I have to give a person a fish until they can learn to fish, I'll do that to get them out of the proverbial hole. And I give the example of a tow truck. So sometimes there's a reason for a tow truck, and you use your prescription pad to get them out of it. And then we, at the same time, are trying to get them to do it by themselves. It's a very simple little thing I put together. We have our adrenal glands. We have our mitochondria in the center. And of course, it ties to everything. Our psychological well-being, our thoughts, how epigenetics alters our genetics, mitochondria again, inflammation, immune dysfunction. They all come in concert, but without our mitochondria, And so one could ponder back to a very controversial topic. At one point in time, once upon a time, there was a eukaryotic cell, so they say. And there was a prokaryotic cell, which ultimately became our mitochondria. Somehow they were in the same time and space. And the eukaryotic cell says, I would like to make this prokaryotic cell part of me. And somehow they decided they were going to exist. And now our eukaryotic cells have mitochondria. I'll just let you figure out how that happened and when and how were they so close to each other. And I was intended to be somewhat facetious, but also thought-provoking. But this is the take-home for my patients, and it's by no means the end of our presentation, but all the ships in the harbor rise with the tide, unless you have a hole. That would be an underfueled tissue of some sort. So think of the tide as the mitochondria energy, ATP production. So we want to rise all at once. So but when you give mitochondrial support, you're going to be supporting everything, good, bad, and ugly. And now we have to, of course, make that energy directional. So now, of course, we now go over to the boardwalk. I think I've shown this slide before in one of my other presentations, but I love to give the example of my iPhone and my apps. My apps are the DNA in various cells. They represent DNA. They're software programs, brain cells, fingernail, hair, maybe not my hair, somebody's hair. And if you fuel it properly, they're going to, of course, have better function. It gives us a full genetic potential. So back to the mitochondria and ATP production. But then we go to histology class. My professor in histology, when I was in allopathic medical school, MD's medical school, was Dr. Guha. Dr. Guha was an Indian gentleman, and we were looking at glandular tissues at the time. We weren't looking at the adrenals, we were looking at the thyroid and thyrocytes and so forth. And he says, can you tell me, and this was back, I'm dating myself here, old woman Bush, remember she had the bulging eyes, God bless her, not her fault, but she had exophthalmos from hyperthyroidism. And he said, Dr. Guha, and I was a smart aleck then as I am now, and Dr. Guha says, what condition does Barbara Bush have? And I said, she has a very grave condition, Dr. Guha. He says, what did you say? And I said, she has a very grave condition, Dr. Guha. And yes, I did say that, and that is a recap of it. But when we look at our histological cells, are they fueled? And if they're not fueled, how can they do their job? So that's why I put this silly little plug in here to the electron transport chain. If you see where I put the little cord, put 3 little pictures together here, we got to fuel it. We have to make that ATP. Otherwise, those cells aren't going to work. No matter how much ashwagandha or rhodiola, if they don't have the ability to take that up and adapt, hence adaptogens, nada. So when we look here at NAD, and we're going to tie into NAD, but we're going to spend quite a bit of time on oxaloacetate today as a therapeutic tool that's been peer-reviewed and actually has been shown to a level and sufficient that the FDA has given it a medical food status for chronic fatigue syndrome. Oxaloacetate, that lovely little intermediary of our citric acid cycle, which when in a stabilized form actually works wonderful. But we look at here, all our little sirtuin pathways, our PARPs and our CD38s. Remember, CD38s degrade NAD. They start cranking and munching our NAD as we get older, even in a disproportional amount. And of course, then we're using sirtuins and PARPs to mitigate immunological aspects of things, and CD38s are also immunological. We start seeing like, wow. And we're going to get to the sirtuins 1, 2, 3, but also 5, which has to do with the mitochondria as well. But 500 different enzymatic pathways for NAD. And these are drugs from a 2008 article that was done by a colleague of mine. And it speaks about drugs that our patients have came to us having been on. And of course, we know all about the MAHA, and Tylenol may contribute to, and then people on social media were swallowing down acetaminophen and say, see, we don't believe those guys. And it's not going to hurt my, like whatever. That's a political commentary, but we know acetaminophen does deplete glutathione levels. We know if you take enough acetaminophen in one fair swoop, good luck if even the emergency room can save your bacon. And one of the therapeutics that they use for acetaminophen poisoning is milk thistle, still to this day. Then we have lidocaine, we have propofol, the Twilight meds, and did Michael Jackson and Joan Rivers die of propofol as they claimed was in their system or some other nefarious process? But you go ahead and you start having these different procedures done. You have certain medications, and then all of a sudden antidepressants like fluoxetine. And it's like, there's 3 fluoride molecules, another thing that might muddle our brains. And then we have our anxiety meds. Now we can throw in here cyclobenzaprine, muscle relaxants, throw in some of the fancier sleep meds. We have our statin drugs. So if our patients are on these are all things that actually alter the mitochondria. They are burdensome to the mitochondria. And there's still, believe it or not, and we know this for a fact, to this day, an argument in the peer-reviewed literature. Do statin drugs lower CoQ10? And I don't care whether they do or not. I'm going to say, yes, they do. I'm going to assume guilty. But they say, oh, no, well, we don't know for sure that they lower CoQ10. So because they're blocking from HMG-CoA down to mevalonic acid, down to cholesterol. But like, I care. I'm just going to assume why not? Because ubiquinol, CoQ10 is ubiquitous. It's essential for our body. So if there's even a question of it's not up to snuff, why not? And then we have our diabetic medicines. We know metformin affects the first phase of the electron transport chain, and of course has some wonderful, interesting off-label drug uses as well. So you start seeing like, okay, well, how do our patients come to us? They came to us through a journey. They come to us in their state, but what got them to that broken state? And so sometimes it's looking back on what meds are on, or I heard earlier from Carol about, well, what happens if they're using a birth control or a vaginal ring, or what got them to that point that is different than a way another woman came to a dysfunctional pelvic region. So let's move on to oxaloacetate. Oxaloacetate, we know, is part of our citric acid cycle. Once again, 7% of more than 7 million people around the world have developed long COVID. If you were to believe that number, once again, statistics are interesting because they kind of make up anything. But it's like, well, let's even say some fraction, like, oh my gosh, the need is tremendous. So symptoms common are, of course, fatigue, the brain fog, shortness of breath, post-exertional malaise, and autonomic dysfunction, including POTS-like symptoms. We're seeing it all in our clinical practice. And if I've seen it, for sure, you folks have seen it. And it's like, okay, well, how do we help? So oxaloacetate enters the picture. And we look at the fact that, of course, we have oxaloacetate, we have acetyl-CoA, and we know we go down to citrate. And of course, we also can say, well, we could feed into this pathway through pyruvate, We have pyruvate dehydrogenase that needs lipoic acid and NAD and so forth for the glucose side of things. We also, of course, could be feeding into the fatty acid oxidation side of things or the protein side of things into that lovely little citric acid cycle that spins off to our electron transport chain. But does oxaloacetate have a function? Well, we know magnesium citrate does. Citrate's important for this citric acid cycle. We know for sleep, a lot of people use magnesium glycinate. These little substrates, these little chelate agents are important. But so they looked here at the oxaloacetate, a key intermediary for the citric acid cycle, and it's gained attention therapeutically for enhanced mitochondrial biogenesis. You can also think PQQ, you can think other things, including hormone replacement therapy, restored NAD, NADH balance, and reduced neuroinflammation. I'm a big fan of something called Blvd. Blvd is a special curcumin that has 65 times more area under the curve, a free curcumin in the bloodstream that actually goes into the brain and the brain circulation directly and avoids first pass in the liver. It's called Blvd. It's a well-studied UCLA patented supplement, but it's curcumin. Clinical studies also show that stabilize. That's a critical thing. Oxaloacetate is oxaloacetate. It has to be stabilized. Can significantly reduce both physical and mental fatigue while improving cognition in patients with chronic fatigue syndrome and long COVID. And beyond that, it demonstrates antioxidant, metabolic benefits, cellular stress balancing out and mitigation, and helps with the bioenergetics of post-viral syndromes. So once again, we're talking about COVID. Well, what about EBV? What about CMV? What about herpes 6? And you can even argue, well, take away the word virus, and we say, well, what about spirochete? Could this help a Lyme patient? I don't know. I'm extrapolating here, but it got me thinking clinically, don't they have a lot of similar burdens, albeit different? But once again, if we take away our ICD-10 and CPT coding, what is going on with the body? It's under attack. It's overwhelmed. The immune system is in a dysfunctional array, and there's an inflammatory cascade going on. So they did some randomized controlled trials, and I can provide you the links to this at the end of our presentation since we're in CME about the actual research, so you can read it yourself. But they did 69 participants. They were randomized. They're either given 2,000 milligrams per day of oxaloacetate or placebo for 42 days. And at 21 days, those taking oxaloacetate said, hey, I'm less fatigued per the DPAL symptom questionnaire, the short form. And total symptom burden was improved at 21 days. That's pretty quick for a person with long haul COVID. And then oxaloacetate also significantly improved cognition, reduced their long haul COVID symptoms, and helped them with overall improvement. There's also another study we're going to talk about how it helped with rapid firing and quicker thinking as well. So in another study, they looked at oxaloacetate for mental and physical fatigue, myalgic encephalomyelitis, chronic fatigue syndrome, or long COVID, non-randomized controlled trial. And they did either 500 milligrams BID, 1,000 milligrams BID, or 1,000 milligrams TID. And they found 6 weeks, very short for these kind of illness. I mean, if you could see anything move around, I mean, that's like the Titanic doing a pirouette. That's very rapid from my clinical experience to see people starting to feel a difference. And they found fatigue reduction, dose dependent. 21% of people at 500 milligrams BID saw some improvement. 27% at 1,000 milligrams BID, 33% at 1,000 milligrams TID. And so right around that 6-week mark, about 48% decline in their symptoms. But there's yet another study, which is very compelling, which I'll share with you, which talks about rapid responders, strong responders, people that actually change that paradigm even more so into like, hey, this group were super responders. So the oxaloacetate improvement of symptoms over 42 days. And once again, the trials, this study is called Regain. But once again, I'm going to give you a link at the end where you can actually go and look at the whole study yourself, because I know if you're like me, you're going to want to read it in order to actually know, can I really believe that and repeat it? So then they looked at, once again, significant improvement on cognition. The AEO is oxaloacetate. And once again, showing the improvement in cognitive improvement and rapid thinking. And here they looked at the group maintaining highly significant improvement, 25 to 35% over baseline fatigue throughout the study. And once again, the oxaloacetate over the placebo. And my patients, I'm thinking of a woman named Brenda. Brenda was finishing her master's as a mature learner. She was in her early 60s. She was just getting her master's degree. And then she got walloped by COVID, and she was not vaccinated. So she got walloped by COVID, and now she has POTS. She spent tens of thousands of dollars pursuing wellness outside of me because I was not having her re-enter my practice. My practice is closed. But I've given her some advice along the way, including oxaloacetate. But her whole life, she wants to die. She actually says, Chris, I just want to go home. That's her quote unquote, her words from Brenda. It's totally ruined her life. So anything that can improve that has caught my attention. So I happen to have my oxaloacetate here because COVID has not been kind to me either. But the enhanced responders is what caught your attention. So if you look here at increased fatigue, lots of people that have chronic fatigue of any sort, long haul COVID or whatnot, they have the ebbs and flows. They get some energy, if they spend their energy, they dip, they get some energy, they spend energy, they dip. There's that classical roller coaster. But then what happened was they were given the oxaloacetate, and enhanced responders had greater than 25% improvement in fatigue. So 40.5% of patients were enhanced responders. That's pretty good. So if you're not 40%, you're going to have greater than 25% improvement. The average improvement for the enhanced responders was 63%. Like, okay, so is there a reason I spent $300 wholesale on a bottle of pills? Yeah. And it's kind of interesting. It's not a sales pitch. I don't work for this company, okay? I happen to know this company and this product because I use it for glioblastoma. It actually has orphan drug status, oxaloacetate for glioblastoma. So it's like, So I happen to have a 30-year-old patient because I do a lot of outreach to the poor. And this 30-year-old guy has a genetic condition that guarantees him recurrent cancer for the entirety of his life. He had a sarcoma earlier in his life. He has glioblastoma at 30. He has a 4-year-old daughter, which is tested. If she had it, she'd by the age of 30 be guaranteed breast cancer. That's how aggressive this autosomal dominant gene is. And so I've given him a lot of oxaloacetate. And so when I heard about this long haul COVID stuff, I'm saying, I got to learn more about this because I'm already using the product for brain cancer. Why not other things as well? So they look at the oxaloacetate, the AEO, and they saw, once again, the mean changes in reaction time. Once again, not only your brain fog, but you feel like you're in molasses in the middle of winter, like very slow, not really a rapid processor. And they saw tremendous improvement, a P-score of 0.0056. Once again, so not only are they less tired, but they're actually thinking a little bit more rapidly as well. And once again, I don't work for this company. There's no company mentioned here, but it is a medically approved food, does not require prescription, but because it is a medical food, requires medical oversight. It's like, no figure. But now let's move to NAD, because I want to be respectful of your time, and I do talk quickly, so we're saving time here. So NAD, I'm not going to be a broken record on this. You've heard me pitch my love of NAD. NAD is necessary for over 500 enzymatic pathways. I can give the same passionate talk about magnesium, by the way, 600 enzyme pathways. Well, let's talk about NAD. This is critical for the mitochondria, which is consistent with our storyline today. And so NAD and its metabolites function as critical regulators. We know that physiologically, helps with xenobiotics. And I'm now helping educate on a new microplastic test, which if you want to know about, you can reach out to me, which actually quantifies how much microplastic a person has in their saliva. And then there's a protocol to deal with that. I'm writing a PubMed article commentary on microplastics and the physiological burden in testing, which I'm hopefully will have done in about a week and a half, assuming I take all my pills in the right array and can actually beat my insomnia. But we see overproduction of free radical damage from stress, damage to DNA, of course, the activation of our PARPs, and these enzymes consume a lot of NAD. But NAD levels, much like ATP, are dropping, all things being equal with age. They found an exception to that. People that walk more than 14,000 steps a day in their senior years don't have drops in their NAD. So the question is it their 14,000 steps that prevent it? And there was no evidence in the research one way or the other. So you walk 14,000 steps, your NAD levels don't drop as you get old, or the NAD levels have a drop, so you can still walk 14,000 steps a day. I don't know. But excess PARP activation, or CD38, which we'll chat about, causes, of course, a drop. It's just like a Hoover vacuum cleaner being sucked in to this pathway. This is a study, and this is all I was allowed to share with you. It's a Harvard study. It's going to get published sometime in mid-November here, but I was allowed to share this with you. It has to do with nicotinamide riboside and Niagen, and you can read about the clinical trial, but it's not been released yet. So this is all I was able to share with you. And they looked at the randomized control, 58 people, long COVID. They gave 2,000 milligrams per day of Niagen, that's nicotinamide riboside. And of course, there's a couple of ways to get Niagen or nicotinamide riboside. 10 to 20 weeks, outcomes were measured: cognition, depression, sleep quality. They saw a meaningful improvement. I have to be careful what I share here. A meaningful improvement in the NAD serum levels. And they started seeing a trending. And of course, as we see in a lot of studies, they say a larger study and a follow-up will need to be done to confer whether cognition and depression and sleep quality were dramatically improved or not. But there was a trending there, but it was an ad hoc commentary afterwards. And that's all I will say about it. It will come out in a couple of weeks. And if you drop me an email, I will gladly share it with you when it does come out. So, but with that, it still comes back to, regardless of that study, and there's another study out of Scandinavia talking about mindfulness and long haul COVID too, and NAD levels, that it's just getting published as well, or just got published. But the mitochondrial dysfunction, key mediator to a lot of disease processes, potential overlap between symptoms of long COVID, of course, identified dysfunction of mitochondria in long COVID. And you see, once again, lots of studies, 2024, 2023, 2025, all talking about, hey, this is going on, but they found that impaired mitochondrial respiration and bioenergetics with peripheral blood mononuclear cells in this group. But how many other people have chronic inflammatory processes and also have PBMC dysfunction? A lot. And so once again, you think about where did we find NAD. I'm not going to read these slides to you. Of course, the TCA cycle, Krebs cycle, and NAD-dependent enzymes. And once again, CD38, part of our immune system, regulating calcium channeling, playing a critical role with T and B cells, leukocyte migration and inflammation. But as we get older, the CD38 sequestering NAD cells start cranking up a little bit more, so we already are depleting it. So once again, is that why NAD levels drop with age? We don't know. But the research shows, as you can see here, effects of stress. If we get psychological stress or physiological stress, and you can argue psychological stress is indirectly physiological stress, we're going to start sequestering NAD levels. And we also will induce NRK1 and 2 conversion of NR into NAD through NMN within the cell, which is a whole nother conversation about what's our preference. We all have our favorite NAD delivery mechanisms. And I'm not going to convince anybody of anything because it doesn't serve a purpose. And any place where I work, I'm an independent educator. I don't own anything. I just love learning. And I love sharing what I've learned. But you see here, mitochondrial overload, your hypermetabolism consumes NAD faster. So there's a fire, you got more firemen and women going over there. They're going to be using more NAD, call it water, to quench the fire, the problems. And so we see, of course, oxidative and genotoxic stress and all these other aspects of things causing a depletion of NAD levels. And we want to sustain this balance. And we have to look at sustained depletion causes a weakened redox. And of course, it causes oxidative damage. Our number one free radical generating aspect of any of our cells is our mitochondria. It's our blast furnaces. And so as a result, that's where 90% of our free radical damage occurs. So if we start getting dysfunction in our mitochondria, we're going to cause more oxidative stress, not only to the mitochondria, but to the cell and to us, the organism. And so once again, elevated CD38. I give a whole lecture on autoimmunity and CD38 and mitochondria, but not for today. And we see an inflammation and further acceleration of NAD decline with age and stress. Being sick, as you see with our patients, and many of us have experienced it, feeling sick and tired, being sick and tired is a stressor. I can tell you that Brenda, the one that wants to die and go meet her maker, as her quote, she quotes it, she says, I'm done. I want to be taken away, kind of like the commercial, Calgon, take me away, and not to make fun of Brenda. And it's like, wow, she's done. She has had this long haul COVID thing, spent tens of thousands of dollars, and she's not better. And she's afraid to start this because she's burnt out. So here's our drop of NAD levels, all things being equal. And they say NAD levels decrease threefold by the time we reach young adulthood, another 2.5-fold by middle age. But now we throw on a physiological burden or a psychological burden, it's going to drop even more precipitously. That's just a duh. And we see our citric acid cycle, we see our lovely oxaloacetate. So we talked about NAD, we talked about mitochondria, but every place there's a little blue star here is necessary to pass, go and collect $200. You need NAD in the form of B3, but of course that's NAD. And it's like, it's a precursor for NAD. And it's like, okay, wow. So we got oxaloacetate here too, and it becomes a rate limiting factor. So whether it be the oxaloacetate or supporting the NAD or both, which is my approach, because I got my bottle of NAD precursor here too. And so we're going to talk about how, once again, we're affecting the sirtuin pathways and so forth. Now I'm going to spend time on this slide. But then we look at the mitochondrial sirtuins and rat adrenal glands. Because after all, that's how we start our talk, on adrenals and adrenal fatigue. But once again, adrenal fatigue is merely a reflection of mitochondrial function would be my argument. And they talk about sirtuins are NAD-dependent class 3 histone deacetylase. And in adrenal cortex, mitochondria are able to transform via the NNT, NAD into NADPH. It's required for steroidogenesis. Once again, how would we as male or female be without our sex hormones? First off, we wouldn't be here because mom and dad wouldn't have been able to come along and procreate us. And then we couldn't sustain ourselves. But they go on here to talk about in the results, sirtuin 3 and 5 were expressed throughout the rat adrenal with the highest level of SIRT5. Once again, what you need NAD for that. But once again, we need functional mitochondria regardless of pulling out one active ingredient. And so we see over the course of time, metabolic stress, cellular damage, and alteration of our PARPs, upregulation, further causing an NAD drop, further causing a mitochondrial dysfunction, and it's a vicious catch-22. We got to break the mitochondrial dysfunction. No different than a lecture I gave 9 or 10 years ago down in Las Vegas at the A4M conference. I call the M&M lecture, the mitochondria and the microbiome lecture, which will be another PubMed article I'm going to be writing, because now it's becoming out there that, hey, the mitochondria and the microbiome work together. Are we surprised? The answer is no. And once again, SARS-CoV-2 actually has been shown to have also altered the mitochondria. And is that another reason where we have 70% plus of our serotonin, 60% of our dopamine, vast majority of our immune systems in our gut? So did we get hit in multiple different ways by this SARS-CoV thing that happened? And the answer is probably. So once again, we see SIRT3-5 are expressed throughout the rat adrenal. So we can surmise probably the human adrenal too. And once again, we look at the mitochondria. SIRT5 is primary mitochondrial sirtuin involved in regulating biological activity of adrenals. Once again, SIRTs require what? NAD and of course lots of mitochondrial energy. And so we see here, once again, that role of things. Once again, I'm not going to read slides to you, but I will point out here, because this is a good point to point out to our patients, access to cholesterol to these enzymes is both rate limiting and the site of acute regulation via steroidogenic acute regulatory protein, the STAR. That's actually what's allowing that cholesterol to turn into pregnenolone. If we have a problem there, or on the outer membrane of our mitochondria or a multi-component transducosome, then we're going to have a lot of problems. So you see lots of references to this commentary. But look at our sirtuins. We know a lot about SIRT1. We know a fair amount about SIRT2. But then we got SIRT5, SIRT4, SIRT3, localization. Per 2011 article here, mitochondria, it's just a take home for today. And we see, of course, NAD biosynthesis. We see this sirtuin-1. Once again, you think nucleus and cytoplasm of all our cells. And then we start seeing, okay, well, look what happens. We have hepatic steatosis, or fatty liver, inflammation, oxidative stress. All of these things are occurring because we're starting to have a shift in our sirtuins. We have to support that pathway. And just another article, but I actually did a very simple summary here. You folks had add another 3 to 10 things. Of course, we got our precursor for NAD. We've got our CoQ10, our pyroquinone, creatine, of course, has regained its popularity. I remember doing radio shows back in the early 2000s. We talk about creatine for this, creatine for that. But now we're talking about creatine again for the mitochondria, adrenal support. And I argue when I do a serum draw, I do a DHA sulfate, pregnenolone. I want to know what those numbers are, because if they're low, they're telling me more about what's going on at probably the mitochondrial level, let alone the steroidogenesis. No wonder we're not making a whole lot of downstream hormones. So I will go ahead and replace DHA and pregnenolone. But with my patient with the pan-pituitary, removal. I diagnosed her with Cushing's disease. She's 83 years old now. 18 years ago, I diagnosed her with this problem. She was a Navy officer when Navy women were not Navy officers. She is very tenacious and love her to death. And they said, no, you're just histrionic. Okay, you're just a woman. They actually told her as much. I'm quoting her, not me. And so we found out she had Cushing's disease. She had a pituitary adenoma. She chose to have her pituitary scooped out through the nasal passages. And she went ahead and is now pan-PID. So 100% desmopressin, growth hormone, thyroid, and hydrocortisone. But the endocrinologists never said anything about DHA, nothing about pregnenolone, but we saw that pregnenolone and DHA and mitochondrial function are critical for the adrenals, and she has no adrenal cortex function, but they have now shown in the peer-reviewed literature that even without pituitary driving, the adrenal medulla can still make norepinephrine, though adrenaline drops, norepinephrine doesn't. Plus, we know in the locus coeruleus, we also do this. But when she recently had a high thyroid, so she's managed by me primarily, but she has endocrinologists at Oregon Health Science University in the VA hospital. And she started feeling really warm and flustered. We found out that her thyroid was 0.2 above on T4 because that's what all their measures T4. So she kind of felt that. So she was becoming a little sympathetically driven, a little hypertensive. And I was managing that with changing some of her meds around, prescription meds. And then I said, let me do a peer review look. So when we increase thyroid, of course, we all know this, but I like it when I see it. It started increasing her cortisol clearance. Of course, it's going to increase every metabolism of everything in your body. So the various drugs she's taking, her metabolism was higher because her thyroid was higher. And I wish I had known at the time where her T4 to T3 conversion was, but that wasn't offered. So I was working off the T4. So I increased her hydrocortisone to compensate for her fact that her thyroid was burning her through. So she was Addisonian and driven by the higher thyroid and blowing through her other meds too quickly, including her lisinopril, which has a 12.8-hour half-life, I give or take. And it's like, So thyroid sped up everything. And because she doesn't have the internal capacity to compensate, I had to make do and compensate for her. And lo and behold, we did. So, but remember how I mentioned how the mitochondria are sped up with thyroid. So her mitochondria, everything was going faster. So she was up bugs hitting the windshield faster. And her personality type, the reason she was a military officer back in the day when women were not military officers in the Navy was because she's a take no prisoner kind of person. But now all of a sudden that drive of hers is driving her nuts. And it was feeding that hypertensive issues. 190 over 120 when she's going to the doctor. And it's like, they said, oh, well, it should balance out. Don't worry about it. You're going to stroke. So NAD levels, overtraining, once again, too much of a good thing. Immune stress, excess sun, of course, environmental factors, alcohol. If you want to see the state of science after we're done with our CME, I will share with you where you can see the state of science and whether or not you like nicotinamide riboside or whether you have another way in which you like to float your NAD levels for your patients, doesn't matter. They actually have a review of course, in our research, but Parkinsonian, Alzheimer's, cardiovascular, athletic performance. So that's all available for free through a portal showing the research, once again, done by that company. So once again, look at our mitochondria. And I have patients with retinitis pigmentosa. It's mitochondrial in large part, genetic, of course, too. Kidney patients, I have a patient right now. He's stage 4 kidney failure. He's a multimillionaire, but he qualifies for disability and free everything because he's now disabled as a multimillionaire. But he also has mitochondrial issues, and he's the one with the 97 cholesterol and a testosterone of 2. But once again, his pregnenolone DHA levels are subpar. Can't I treat those as long as I don't increase his testosterone? Question mark. Because once again, he's on an androgen deprivation program. And so these are, of course, things in the peer review literature. Once again, this article was mine at ndnr.com. And if you type in oxaloacetate, it'll pop up. But the different things that they're proposing for long-haul COVID, for spike proteins, and some NAD support, oxaloacetate, silymarin. Of course, if you're familiar with zombie cells, that's the colloquial term. doing a 3 to 4 days a month of phycine and other things to kind of clean out our zombie cells, our hypersenescent cells, which are like leeches or barnacles on the bottom of an old wooden ship. So my approach: minimize stress, L-theanine, rhodiola, or rather Relora. Lots of research on Relora, by the way. Just type Relora into PubMed. 2 or 3 nice articles come up if you're not already familiar with it. Sleep, rule out sleep apnea. Deal with your partner in a humane way that snores next to you. Avoid this. And Shin Yuku, and I pronounced the R last time I gave a webinar on forest bathing, a different lecture. And I went to the Japanese gardens here in Portland, which is known to be the best Japanese garden outside of Japan. And I happened to be a Japanese volunteer there. She says, Shinyan Yoku? And she didn't pronounce the R, which reminded me of my office mate, which was Japanese. Nate was going to name her child Eileen. They was not going to say Irene because she doesn't do R's. Go figure. So Niagen, mitochondria support, adaptogens. And I'm a big fan of this one, the fortune cookie here. Penny saved is a penny earned. And we need to ground ourselves. I got grounding mats all around me. I try to open my window, get fresh air. Of course, I have filters because indoor air pollution exceeds outdoor air pollution most of the time. Adrenal balancing and individualized nutrient testing. You already know that. But I will do a neurotransmitter test. I don't end all be all treat people and their brain chemistry by this. I like to see what their norepi, GABA levels, kind of like to see a balance of things. Once again, I'm not going to put a lot of weight on, just like I'm not going to put a lot of weight on a hair analysis for balancing out minerals, but I like to see kind of what the body is telling us. And so I'm going to open up for questions. My next slide is non-CME, so I'm going to leave it here. Questions?
Okay, anybody have any questions? Dr. Nario, got anything online?
Yes. Do you have anything on the chat, or
No.
you just want me to go?
Actually, no.
Okay. So, Dr. Meletis, thank you so much for that great presentation. I think one of the things that you brought up here is the one that kind of made us all curious. I mean, even the questions. Oxaloacetate. So that's really, I don't think it's new. I've been using it myself. I've been using it on patients. But this is something that they definitely wanted to kind of ask more about. So one of the questions here is, when you mentioned about that oxaloacetate is safe for long-term use, what typical clinical responses do you observe when you're using oxaloacetate? So you did mention that it kind of tickles the TCA cycle. So obviously it's almost like an energy-producing type of supplement.
Yeah, it helps with the biogenesis. It helps sequester and deal with oxidative stress. And once again, I don't work for that company. I've just learned as you folks have learned. So I am probably 12 weeks ahead of you folks. And I've used it as well, just like you have, Doc, but I haven't used it for chronic fatigue and long haul COVID. So the only side effect I've noticed is about 3 to 5% of people get headaches with it. And that's the only downside I've seen with my patient base. But once again, I've only been using it for this particular application for a short period of time. The owner of the company, which is a researcher and a very gentle soul, is not promotional, but he's at every big conference. And I have on, when we're not seeing me, I'll share with you the contact information where you can all read the research and come to your own conclusions. But the stabilized form is the proverbial cat's meow. And they've came up with a higher dose, 500 milligram pill. So 2 pills 3 times a day. And if you're a high responder, and then all of a sudden you're getting lots of even greater than a 25 to 35% benefit.
Right. So this is not a cheap supplement, if I may tell everyone, because
No.
I also know the one who makes it. I see them in A4M conferences, and I don't think it's a big company. So
It is not a big company.
it is not. Yeah, but the thing here is it brings a lot to the table if you're talking about anti-aging remedies here. And another good question here would be, so you also discussed NAD along with oxaloacetate therapy. So from the sound of this is something that people can actually do together, as you kind of emphasized. But is there such thing as overdoing? You're actually promoting NAD formation with oxaloacetate already. Now you add your other supplement that adds more NAD. Is that the overkill, or is that something that's pretty okay? The body modulates that on its own.
And the moment we're not in CME, I have a slide that shows a testing methodology. There's 2 or 3 laboratories now at measuring NAD levels and that whole test don't guess approach to life.
Mhm.
And so can we quantify? I rarely quantify NAD levels for a person at the start, but if I'm looking to see whether I've hit a threshold, because of course we do an IV shot, an injection of precursor molecule or NAD for that matter, but let's say you use nicotinamide riboside injected because it doesn't have some of the sequelae or side effects of NAD in terms of feeling like you're having a massive heart attack as much, as well as the other side effects. And it's much more rapidly delivered than NAD through NAD IV. But so I give the example of a clothesline. So if you're doing some sort of intravenous or IM injection or sub-Q injection, you're going to get a person's levels up higher, but it's super physiological potentially. Then it's going to dip like an old clothesline or telephone line. I will go ahead and supplement and then do oral in between, but the more dramatic bolus dosings. But I like to then at that juncture somewhere after a few weeks measure their NAD levels and say, have we got them there? Or they're subpar, or are they super physiological? Because they're, in my opinion, on anything, there's too much of a good thing. I mean,
Right.
I think one of my favorite lectures I used to give at our local medical school was just because it's natural doesn't make it safe. If it has the power to be physiologically impactful, and so it can also be a bullet in a china shop. So I think there's wisdom there.
Right. Well, you brought that up, so that's actually a good point of discussion there. That not all supplements are actually good, especially if you're doing it too much. One thing that you would hear from oxaloacetate, or even adding NAD in there, and you probably have answered this, and now we're talking about the synergy, or maybe specifically about oxaloacetate. So now we're talking about hypermetabolic conditions. And if we mentioned about producing more ATP and reviving the mitochondria, so what about hypermetabolic conditions such as cancer? Is oxaloacetate another one of those controversial supplements like NAD? When you use it, would you rev that up also? Or that's not, you mentioned about glioblastoma a while ago. So
Yeah,
that's actually something that's pretty curious when you mentioned that.
yeah, actually, and once again, I don't speak for the company. I don't work for the company. I just happen as when I come across cool things, I like to share cool things. I met this gentleman 12, 14 years ago at a conference.
Yeah.
And I just started chatting with him because he's a pleasant conversationalist. And then I just, the glioblastoma, astrocytoma, the research orphan drug status. But it has an impact on the Warburg effect. And he can actually speak to that. I'm not going to speak to that because we're being recorded. And as a naturopathic doctor, and probably all of us, unless we're oncologists, we're not allowed to talk about that C word. I get even the COVID word's kind of questionable, but the other C word's really questionable, at least for my line of work.
Right. Yeah.
But
So anyway,
but
yeah, that
I'll share a personal pearl. My
sure.
sister, by 2.5 years younger than me, was diagnosed with inflammatory breast cancer February of 2022 here in Portland, Oregon. She was told to go onto hospice because I'd gone from one breast to another, so she was considered stage 4. And that was back in the February. Her birthday is February 22nd, by the way, or February 2nd, Groundhog Day of all things. And so she went down to MD Anderson, had a mastectomy because they called it regional stage 4 that allowed them to do what they needed to do or wanted to do. And she's still alive, but she's implementing oxaloacetate based on some research.
Oh,
And once
okay.
again, the question is now NAD, and there's a beautiful lecture series that just happened this weekend, all on cancer. It's called AAMP, ran by Dr. Paul Anderson, if any of you know Dr. Paul Anderson.
Yeah. Mhm.
And they were talking about the whole mitochondrial dysfunction. And if we feed a aggressive cancer cell, I call it the pig, because it takes up a PET scan. It's like, nom, 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 I'm going to take up all the sugar. But of course, we know they're metabolic dynamic. Sometimes they'll go for glutamine. Sometimes they'll go other ways. Sometimes they'll say, hey, give me all the keto you want to give me. And so then if you have a CHEK2 gene mutation or a BRCA1, which my sister has both of those feeding against her, it's scavenging everything because everything is fair game. So we're trying to balance out the Warburg. We're trying to balance out copper zinc ratios. She's still alive and she's tenacious as all get out. But she has a hemoglobin of 7 right now. And it's nip and tuck. And does she still have
Right.
the opportunity to get there? But she's using oxaloacetate as well because we're trying to play around with the Warburg effect because her restrictive diet. She's done everything under the sun that any of us can imagine. She's done EBU, she's done IV vitamin C, she's done artemisinin, she's done milk thistle, off-label drugs, and she's willing to throw everything at it. So if anybody has any clinical magical pearls, I know there's no claims, feel free to reach out to me. I'm big brother, and that happens to also play doctor some of the time. And I'm going, I just want to help the poor thing. And her kids are a decade younger than mine. So they're 17 and 22. Mine are 27 and 32. And
Right.
they need mom.
I know. Well, she's in good hands. You kind of have all the gambits and all the
But I'm
perks.
open. I stay humble. And when I sit, honestly, like I said, my favorite group to speak to is your group. You folks have been
Thanks.
doing it. You're in the trenches. And I just, whatever you folks might have to offer, I'm game.
Yeah, I'll help you out.
And off the record, just say, hey, Chris, random idea, take it for what it's worth, no liability associated with it. Yes, that's how I give my sister advice. I'm not telling you to tell your medical doctors anything. Just you might consider.
Put your email on the chat. I'll send you some because I see cancer patients here in Reno, so I can definitely slip some through you.
Okay.
But yeah, I'm sorry to hear about that. That's really tragic.
But that's how I addressed your oxaloacetate question in cancer.
Yeah,
So-
and then one thing that actually caught my attention about oxaloacetate, but actually the initial studies about this in 2014, that they use it on C. elegans worms, and they actually saw the lifespans of these worms increased by 25% when they actually were given oxaloacetate. Though they're not humans, as you can see, but again, I mean, what if it can actually transpire if it's a human use, and you can get that as well? We just don't know, right? But that's one of the curiosities that I have about it, and again, even the studies. So I started to use this now with my patients because the 2016 study about oxaloacetate, about the chronic fatigue, even though it was small, it actually, they used 500 milligrams twice a day, and it improved energy and mental clarity for just 6 weeks. So according to your studies as well, that's basically, again, evidence-based medicine at its best, that you can definitely give that to your patients, and you have those tools behind you. So, but again, oxaloacetate, I'm sure everybody's knew about this. It's not really, but let's spread the word. And now we're making noise about this supplement.
And once we're not on CME, I'll go to the last slide.
Okay.
Right.
Dr. Naria, you got any more questions for the CME folks?
No, that's it. I think it's all about oxaloacetate. So you got the ruffles of the feathers going here with that topic.
Okay.
So oxaloacetate is what's really driving my conversation. NAD is an area in mitochondrial passion, but the oxaloacetate just caught my attention. And and I'll be a full disclosure, as a gift to them for helping my patients in a very favorable fashion with glioblastoma. So let me write you a few articles. I wrote NDNR, I wrote Townsend Letter, wrote one for chiropractic economics, just all for free, not working for them, just to pass the word out there that if we can help one more person with one more tool that might make a difference in their life and their generational downline, wonderful. So for those that want to see the research on NAD, yes, it's NR biased and Niagen biased, but it's pro.truniagen.com. When I say biased, it's talking about NR, but it's really NAD research. They've increased NAD levels and they have neurocognitive. So they have what's called the state of the science on that website. And they will then, you can run through that and look at just the state of science and then use whatever application you want to use to augment NAD. They also have a home test for looking for NAD levels. Then the oxaloacetate C